I put that in the script. Yeah. So if you'd like to watch this again, or for anybody who's not able to watch it live, we'll have it on our YouTube channel. So welcome to our webinar, which is brought to you by the Marfan Foundation and Marfan Trust UK. Our topic, as you know, is the medical management of Marfan syndrome, which we are presenting in English today, but in French and German later in this month, which is Marfan Awareness Month. And we're thrilled to have Dr. Alex Pitcher with us as our presenter today. More than 200 people registered for today's webinar from both sides of the Atlantic. And again, so great to work with Victoria, who I got to meet in person a couple of years ago. And it's really important that we do these educational programs together that truly empower people affected with Marfan syndrome and their families around the world. So I just want to give Victoria a chance to say a couple of words. And there we are back in Paris. So Victoria.
Hi there, just continuing and echoing Eileen's welcome. The Marfan Trust is very happily collaborating with the American Foundation on this and future events. We'll soon be staging an in-person patient information symposium this August on the 31st. It's in London, but the venue has yet to be established, and we'll be sure to keep you posted. But we're particularly excited to co-host tonight's webinar with Dr. Alex Pitcher. As Trust supporters probably know, our medical director, Dr. Anne Child, worked with Dr. Pitcher on the AIMS trial, reaping fantastic results and demonstrating that angiotensin receptor blockers show significant reduction of aortic root enlargement in Marfan patients. Anyway, that's all from me, except to apologise to any supporter who's logged in as me this evening. In a comedy hitch, I think I inadvertently sent you my own personal login for the webinar. So sorry, back to Eileen.
Okay, thank you. And thanks for mentioning that international patient meeting that we're going to put together. We've got a great planning committee together. We're going to be working together to put it together for August. So anyway, a couple of details before we hand it over to Dr. Pitcher. So there's a Q&A box that you'll see next to the chat box. So if you have any questions during this presentation, put them there. Maybe listen to the presentation first, because maybe Dr. Pitcher will actually answer your questions before we get to the Q&A part. And try to keep your questions short and general, rather with all your personal medical information, because we need to be able to read it and then be able to ask him the questions. And as Victoria said, some of you have her login and your name might not come up. So if you have a question and your name doesn't come up, it'd be better to put your name and email in there. And if we don't get to it, then we can at least follow up with you and get you the answers. Also, we have a help center, and I'll put that link up later, where Jan, our nurse, can also answer questions. So anyway, we're here for you, and we're ready to introduce our speaker, Dr. Pitcher. Victoria said a little bit about him, but also, as many of you probably know, he's a consultant cardiologist at Oxford University Hospitals and clinical lead for integrated community cardiology. His general cardiology practice encompasses all routine aspects of inpatient and outpatient cardiology, and a specialist practice focuses on disorders of blood vessels, including Marfan syndrome and Loeys-Dietz, and pulmonary vascular disease. His research interests are mainly in large-scale data applications to rare diseases, particularly Marfan syndrome. And he's published extensively on Marfan. And of course, we all know about the meta-analysis of the randomized trials from around the world on losartan and beta blockers. So Cheryl will be talking about a lot of that today. And so I'm going to stop sharing and let him take the remote control, and we can't wait to hear from him. So, and I will hide myself as well. And you're on mute, so you need to unmute there, Dr. Pitcher. There you go.
Is that good? Yeah. Hi, everyone. Thanks very much. I'm still.
You can just share your slides, and it's all
yours. I'm just going to. Hi, everyone. Thank you so much for organising this. I want to thank everyone at the Marfan Foundation and the Marfan Trust for the incredible work that you do, supporting patients and clinicians and scientists. Both organisations have been tremendously helpful to me, and I wanted to thank you for that. And also I wanted to thank you for the opportunity to come and talk to everyone tonight or this afternoon for those in the US and Canada. I wanted to thank everyone for coming along. It's a great turnout, but slightly intimidating audience of people who I know are very knowledgeable about their conditions. But anyway, I'm really looking forward to it. I plan to talk maybe for about half an hour or so, and then I'll shut up, and you can ask me any questions you like, and I'll try my best to answer them. Okay, great. So if I can figure out how to share my screen. It says that the host has disabled participants' screen sharing.
Nope.
Okay.
Here we go. Try it now.
Try now, yeah.
You
Okay.
you got it right.
Yeah,
Sorry.
let's try that. Share screen. Yeah, this is looking good. Yep. Okay, good. So if I just share this screen and go into the, I need to go into the right mode now, don't I? Yeah, there it is. Yeah.
Got it?
Yeah, that should be it. Yeah, great.
Yep,
okay.
you're good.
So I've been asked to talk about thankfully, the area that I know most about, which is what I think of as the medical treatment of Marfan syndrome. What do I mean by medical treatment? Well, that really is the medications as opposed to the other aspects of treatment, which I think are extremely important, which I think of as the lifestyle measures and also surgical treatment. We could talk a little bit about that later if you want to, but they are important. So I'm going to come on to that in a second. So I'm going to tell you at the beginning what I want you to take away as the main messages, and then I'm going to go on to talk in more detail about it. And at the end, I'm going to tell you what the main messages are again. So I'm going to tell you 3 times basically. So the first message is that the lifestyle measures for patients with Marfan syndrome are important. And if you're a patient with Marfan syndrome, you can control these to a very large extent. So I don't want anything that I say today to detract from that very important message. Looking after yourself, looking after your body, looking after your aorta is a really important part of Marfan syndrome. And you are the main person who's in control of those. And you can get lots of good advice from your care providers. And if you're not getting good advice, then you need to ask them for it and get help with it. The second thing is that, and I think this is a really optimistic message to come out of the meta-analysis and the studies that everyone has worked so hard on, is that there are now 2 proven, to my mind, and I'm going to show you the reason why I think it's the case and explain the reason that I use that word proven, classes of medications that have been shown to reduce the rate of aortic enlargement in Marfan syndrome, and that these medications or classes of medication are effective when used alone, and you can choose either one, or you can choose both. And I think they are probably most effective when they're used in combination. And if you use both medications, you probably get an additive effect, and the 2 drugs work together to give you double the benefits. And so I think that's a pretty positive message. And if I had, Marfan syndrome, I would want to give serious consideration to taking both of these classes of medication together. That's what I'd want to do. Now, if there was some reason why I couldn't take one or the other, then that's okay. I would just take the one that I could take. But I would want to be thinking about taking both. They're also generally very well tolerated medications. Most people can take one or other of the medications, and many patients can take both. There are also some medications that should be avoided. Now, most of you are not going to ever need these medications, but I think it would be nice for you to know what they are in case the circumstances arose where a physician might want to put you on these medications, and you could say, I think I'll pass on that one, or do you have an alternative? And of course, there is the option of surgery to the aorta, the main blood vessel, if that ever grows too big. And that's a really good treatment option. And surgery on the aorta, especially the part of the aorta that is most vulnerable in Marfan syndrome, we'll talk about that, is now an effective and generally low risk option, but it's not risk free. And that's why we want to look at things like lifestyle measures and medications to try and delay the need for surgery, or in some patients, perhaps even remove the need for surgery. So we want to use all the tools in our toolbox. And it's my belief that if we use all 3 treatment options, lifestyle, medications, and surgery, we can get the best outcomes for patients. That's the goal. So those are the main options. I'm going to repeat all this at the as we go through the talk and elaborate on these things. And at the end, I'm going to come back and summarize it all again. So what issue am I trying to resolve? Now, Marfan syndrome obviously is a multi-system disorder. It affects the eyes, it affects the spine, it affects the musculoskeletal system. In fact, it affects many parts of the body. Some might say it affects every organ system to some extent, sometimes just trivially, but sometimes quite seriously. But I think that the effects on the cardiovascular system are by far the most serious in terms of impacting a patient's longevity, how long they're going to live. Now, there are patients with Marfan syndrome whose life expectancy is unaffected by Marfan syndrome. I have at least one patient I can think of. I've got one chap who comes to my clinic who is 81 years of age, who has definite Marfan syndrome, and he has never had any heart surgeries. He's never had any surgeries on his blood vessels. He was treated, for the first 50 years of his life. I don't think he had any medical treatment. And even in later years, he didn't have much medical treatment, probably just a beta blocker. So, we haven't done very much to him. He's lived for 81 years without much treatment. So it's certainly possible to live to very advanced ages with Marfan syndrome and not have serious cardiovascular disease. But many other patients do need to have either they need medications or they need surgeries or they run into complications. And so that's what we're trying to deal with is that, I focus on the cardiovascular manifestations, and in particular, I focus on problems of the aorta. So I know that probably most of you already know this. Most of you do. But I guess it's just possible someone on the call has just recently been diagnosed and this hasn't come up yet. And I think that perhaps something that people don't fully appreciate is that this usually begins and mainly affects two specific parts of the aorta. And the most vulnerable part is this part here. So here's the aorta in the chest. It is, of course, a gigantic blood vessel. People often are very shocked to learn how big it is. I always say it's the biggest part of your body that no one's ever heard of. And, it starts here just at the heart. It then loops up around just under the neck, giving off these branches to the arm and to the head. And then it loops around like this. This is the arch of the aorta. And then it loops down through the chest. That's about a foot long, or, maybe that kind of thing. And then it sort of goes down through the diaphragm into the abdomen, then through the pelvis, and then it sort of halfway down the abdomen, it splits around about where the navel or belly button is here, and then splits into these two big blood vessels here. And usually here it is sort of taken out, and this is the aortic valve. And then this very first part here is called the aortic root. These two very, very important blood vessels, the coronary arteries, come off here. This is what causes, in generally older people, causes coronary artery disease. That's not a feature of Marfan syndrome, that's different. But this is the part that tends to swell in Marfan syndrome. And if it gets too big, that's when there is a risk of tearing of the aorta here. And this is where the risk of tearing is very serious, because it can disrupt the aortic valve, it can disrupt the coronary arteries, and it can run back towards the heart. So that's what we want to avoid. And then there's another area of vulnerability just here, where the aortic arch meets the descending aorta. And when they have a problem here, it tends to cause tearing called a type A dissection. And when you have tearing here, it tends to cause what's called a type B dissection, generally speaking. So that's the issue that we're trying to prevent. And we're trying to slow down the growth of the aorta here and here. Now, we get these things called aneurysms, which are sort of swellings of the blood vessel. And here's one type of aneurysm, and here's another type of aneurysm. And you can get aneurysms anywhere along the aorta. But this is the kind of aneurysm that you tend to see in Marfan syndrome and also other conditions like Loeys-Dietz syndrome. And it's right down at the root of the aorta. You don't see this you see this in other conditions. You see this like this. It's like a flask that we used to use in school in chemistry lessons, like that. And that's what it looks like. And if I go to the next slide, this is what the echocardiogram looks like. Now, this is the same aorta, but it's just been tilted 90 degrees on its side. This is what a normal aorta looks like. Here's the heart, here's the aortic valve, here's the aorta, and here's the little flask. This is what a normal one would look like. And here is what one would look like in a patient with Marfan syndrome, where the aorta has been allowed to grow far, far too large. Each one of these markings here is 1 centimeter. So this is probably 1, 2, 3, 4, 5, 6, 7, 8.5 centimeters. That's crazy too big. So and here's the aortic valve. So, and this whole thing has got far too big. So that's what a Marfan aorta would look like on an echo scan. So next, I just want to change topic before we come on to the real substance of what I want to talk about. But I just want to make sure everyone's on the same page with understanding what a randomized controlled trial is. Some of you are going to know all this already. Some people maybe not. So I just want to make sure everyone's clear about it. So in a randomized control, I mean, some of you will have been in randomized controlled trials, I know. So the idea of a randomized controlled trial, it hasn't been around for the whole of human history. This concept was invented in the 1950s. It's a British invention, I should say. And the idea was that you take participants who have got the disease that you want to study, let's say patients with Marfan syndrome, and then you want to test whether the treatment works compared to no treatment. And so what you do is you randomly allocate, let's say, half the patients to having the intervention that you want to test, let's say the medication, and the other half of the patients are randomly allocated to not getting the treatment. And this idea that the treatment allocation had to be at random, it was not obvious to human beings until really about the 1980s. And it's kind of amazing that this hadn't really become clear. But until the 1980s, it was extremely common for people not to be allocated at random. And what would happen is the doctors would decide which group it would go into. And you would think, oh, well, and the doctors who did these trials before the 1980s used to really think that they could decide in an unbiased way, but they really, really couldn't. And we have learned the hard way that if you want to get an unbiased group, in other words, if you want the people getting the treatment group and the control group to be similar in terms of their composition, you must randomly allocate people. And so if you ever see a trial or a study that's purporting to show that a medication works and there's no randomization, there is no random allocation of people to treatment or no treatment or to different treatment arms, then alarm bells should be ringing, and one has to treat that with a significant amount of skepticism. And then what usually happens, and what happened in the trials of the treatments that I'm going to show you, is that measurements were taken of people's aortas at the beginning of the trial, and then they continued to take measurements throughout the trial, and then they take a final measurement at the end of the trial. And so for each patient, it was possible to see how that patient's aorta was behaving over the course of the trial. And then you could work out whether the patient's aorta was growing, and if it was growing, how fast it was growing. And that's how the trials of Marfan syndrome were conducted. So that's how these trials were done. Now, we have in the sphere of what's called evidence-based medicine, which is the way in which you try to apply evidence and science to patient care, this kind of pyramid of a hierarchy of evidence. And so in the past, we used to rely very heavily on experts' opinions. So, a professor or a specialist would say, "This is what I think we should do," and nowadays we put that really at the bottom of the hierarchy, because we've realized that experts got it wrong a lot, and it was very much biased by what the sort of loudest voice in the room was, and the most sort of most outspoken person sort of felt. And then over time, ideas tend to get tested in various kinds of studies. And then here we have these kind of non-randomized trials where there was medications were being systematically tested, but without randomization. And then there was a feeling that randomized controlled trials were probably better. But then we had a situation in which often people would do several different randomized controlled trials. Maybe there'd be a randomized controlled trial in France, there'd be a randomized controlled trial in Spain, there'd be a randomized controlled trial in Canada, then there'd be one in the US. And sometimes they would all say the same thing. Well, that's pretty easy. And sometimes they would say slightly conflicting things because they tested things in slightly different ways. Maybe they'd use slightly different medications. Maybe the populations they were studying were slightly different. And then there would be various different ways of looking at overviews of these trials. And sometimes experts would get together and say what they thought were the best ways of doing these trials. But finally, people developed systematic ways of putting trials together. And there is a special way of putting trials together that is called the meta-analysis. And the correct way of doing a meta-analysis is to bring together the trials. And this is the clever bit, is that you essentially add together the information in all those trials, and you weight the trials according to the amount of information that is contained within each trial. Now, that is very, very misunderstood. And if you understand that, what I just said, you know more about meta-analysis than most doctors. Okay? Meta-analysis has a slightly bad reputation, particularly in the US, I should say, because there are lots of different, for two reasons. One, most doctors don't understand that sentence that I just said. And number two, because there's lots of ways of doing meta-analysis wrong. And there's only really one way of doing them right. Okay, but if you avoid those two errors, you understand what meta-analysis done correctly really is. It is putting together trials in a logical way in which the information, in which the trials are weighted according to the amount of information that each trial contains, and that you do the analysis correctly and you don't make the mistakes that are easy to make, then the meta-analysis is the best way of making the correct judgments about the way in which one should proceed. That's the concept. Okay. Well, that's my belief anyway. Okay. So I want to talk now about the two different classes of medications, and we're going to dig into this in a lot of detail, and people are asking really sensible questions in the Q&A. And I'm going to answer all those questions in the slides, I hope. And if I haven't, we'll take them up in the Q&A. Okay, so the first class of drugs I'm going to talk about are angiotensin receptor blockers. And then we're going to talk about beta blockers. And we're going to talk about who benefits and all this kind of stuff. Okay, so let's give the top level view first of all. So angiotensin receptor blockers in Marfan syndrome. So I'm going to talk about these things called ARBs, okay? And angiotensin receptor blockers are these medications like losartan and irbesartan and telmisartan and olmesartan and anything ending in sartan, essentially. And I'm just going to call these ARBs to start with, okay? And in a minute, I'm going to talk about which one's best and all that kind of stuff. But for the moment, I just want you to think about the classes of medications. Essentially, these medications have been around for about 30 years, and They have been used for hypertension. They've been used for patients who've had heart failure, and there are many hundreds of thousands of patients throughout the world who've been prescribed these medications. And the concept essentially is that in Marfan syndrome, the problem is here. The fibrillin microfibrils are disrupted and do not work. And as a consequence, we think that these fibrillin microfibrils cannot effectively bind a medication called TGF-beta. That means that this TGF-beta is dysregulated. As a consequence, there is excessive signaling through TGF-beta, and that means that TGF-beta is signaling excessively, and so making the cells in the TGF-beta in the smooth muscle of the aortic wall do things that they shouldn't do, and causing the chemicals inside the cells to signal excessively. This is not good for the way the cell is behaving. That can be resolved by giving treatment through this pathway here, which is the angiotensin receptor pathway. And that if we block signaling through this pathway, it is possible to interfere with this signaling pathway because these pathways here link up inside the cell. That's the concept. It's a little complex, I understand, but the evidence is here. So this is evidence from Dr. Loeys-Dietz, who many of you will have heard of, and many of you I'm sure will have met and listened to at various times. This is the aortic wall of a mouse, a normal mouse, the so-called wild type. These are mice that live in the wild, I guess, and they have these beautiful architecture to their aortic wall. The black lines are the lamina, the elastic walls of the aorta, and then in between is where the cells live, and everything here is beautifully organized. Here is a mouse with Marfan syndrome who has just been treated with a placebo, just a sugar pill. It's not doing anything to them. So this is a Marfan mouse. And what you can see is that the aortic wall is really thick. You might think thick is good, but it's not good, because what's making it thick is there's a load of expansion of stuff in between the good elastic walls, and the elastic walls are all broken down. And this is not good tissue. There's holes here, there's gaps there, and this is a good tear. So this is bad aorta. This is not going to keep the aorta looking good for long. This is not good. Here is what happens if it's treated with beta blockers, propranolol, which is normal treatment for Marfan syndrome. It's probably a little bit better than the bad aorta, but it's nowhere near as good as the good healthy aorta. Here's what happens when the mouse is treated with losartan, the angiotensin receptor blocker, and this effectively has prevented the mouse from developing these bad changes. So that's what happened in the mouse, and here's the wall thickness. This is the normal mouse. This is the mouse with Marfan syndrome with no treatment. This is the mouse given the angiotensin receptor blocker. Okay. So a number of trials now were then undertaken, and we then organized with the investigators who did these trials. We put these trials all together to try to give a definitive answer, because the trials were confusing. As the trials were coming out, they started to say kind of slightly conflicting things, and it was a confusing picture. And it was only really when we put the data together that a clear picture, at least to my mind, emerged. And I think I can hopefully explain it in a way that at least makes sense to you. And I want to share it with you in a way that hopefully will make sense to you as well. Let me take you through it. So first of all, I want to talk you through these 4 trials. So there were 4 trials that essentially asked the same question. There was a trial from France. There was a trial from the Netherlands. There was the AIMS trial, which Anne Child was heavily involved with from the Marfan Trust. And then there was the trial from Belgium, which were all fundamentally trying to ask the same question, very similar question. What these trials were doing is they were comparing angiotensin receptor blockers with a placebo. medication. So they were comparing the same thing. What is it better? Essentially, they were asking the question: are angiotensin receptor blockers better than a sugar pill, effectively? And they differed by size. So this trial had 299 patients. This trial had 233 patients. This trial had 192. And this trial had 22 patients. And so you might say, okay, well, it's not fair to compare, to include this trial with this trial, because this trial was much bigger than this trial. And if you thought that, then you understand meta-analysis, because we didn't add those trials together in a lump and just say, well, okay, that's one trial, that's two trials, three trials, four trials. We weighted the trials according to the amount of information that they contained. And this trial contained an awful lot more information than this trial. So this trial got given more emphasis in the meta-analysis than this trial. And a lot of people didn't understand that, okay? There were certain trials that did very, very precise measurements of the aorta, and there were other trials that did slightly less precise measurements. They just kind of, yeah, it's roughly there. And other trials really measured it very precisely. And some of the trialists said, well, I don't want my trial being mixed in with the guys who just kind of went, yeah, it's roughly there. And I said, don't worry, because we're going to weight the trials by the amount of information available. So if you did really precise measurements, we know that, and we're going to put more emphasis on your trials. So that's the beauty of meta-analysis. We know which trials provide the most information, and we can weight those trials accordingly. Okay, so the trials made frequent measurements. So we got huge amounts of information for every participant. And they were measuring the aorta at exactly the place where the aorta tends to enlarge. Okay, so that's the characteristics of those trials. I'm going to skip this trial and come back to it. We published the protocol before we knew what the trials were going to show, so that there was no opportunity for us doing, statistical jiggery-pokery. We said what we were going to do, we did it, we found the results. There was no opportunity for clever statistical messing around. And we analyzed all eligible randomized trials that were done in the world that provided data to us. We used individual patient data, and trials were weighted according to the information that they contain. Okay, the primary aims that we wanted to estimate the effects of angiotensin receptor blockers and beta blockers on the change in aortic root size in patients with Marfan syndrome who had no prior aortic root surgery. There's no point in including patients with aortic root surgery because they've already had their aortas replaced with a piece of surgical material. And so that would have affected the results in a way that was unhelpful. And then we had various secondary aims as well to look at different subgroups. Do children benefit? That sort of thing. So we looked at various other secondary outcomes as well. Okay, so let's look at the results. So now this looks a little complex, but it's really pretty simple. So I just want to spend a minute talking you through this. So these are the names of the trials that we just talked about. Here's the French trial, here's the Dutch trial, here's the UK AIMS study. Some of you may have been participants in that trial. Here's the Belgian trial. Okay, and these are the names of the trials. This is the annual change in the size of the aorta. So for each year that the participant was in the trial, how much bigger did their aorta get? These are the participants who are on the drug treatment, and these are the participants who are taking the sugar pill, the placebo medication. If the trial found that the angiotensin receptor blocker was better for the patient's aorta, then the black dot here would be shifted over to the left-hand side, like this. And if the trial found that it was actually better to be on the placebo medication, then the black dot would be shifted over to this side. And then the diamond represents the overall result. So when we looked at the results, the first thing my eye went to is, did this diamond fall on this side or did it fall on this side? And if there was no difference, the diamond would have fallen bang in the center. Okay, and the further the diamond is to this side, the more the ARBs work, and the further to this side, the more the controls work this side. And if the diamond is completely on this side, then we are can be certain, or more certain within certain confidence limits. That's a kind of statistical term, that the treatment works. And what we can see is that the diamond falls completely on this side of the black line. If the diamond had been falling over the line, so half the diamonds on this side and half the diamonds on this side, then it's a wash, and that neither treatment works. That just means that the drugs do nothing. So what we can see is the diamond falls completely on this side of the line, and that tells us that the ARB is better than the no treatment. And the fact that the diamond falls completely over the line means we can be 95% confidence that that result is true, more or less. It's not entirely right, but that's basically it. So that was the kind of key finding of the meta-analysis. And then the next thing to look at is, well, how big is this effect? Are we saying that the angiotensin receptors reduce the rate of aortic enlargement a tiny bit, or is it a lot? What does that mean? Well, let's look at this. So per year, the aorta was enlarging by 0.13 units here, and if you were on treatment, it was 0.07 units here. Now, 0.13 and 0.07, this is about half of that. 0.1, if you double 0.07, you get 0.14, don't you? So 0.03, 0.14, it's about the same. So effectively, what's happening is the ARB is halving the rate at which the aorta enlarges. That's huge. Okay, so like if there was a medication that would give me half my hair back, I'd take it. Okay, so halving the rate of hair loss would be huge for me. Halving the rate at which my the aorta was expanding for you guys is really, really big. Okay, so that's a really big effect, and on a statistical level, I'm quite certain about it. Okay, so that's what that showed. And then there's various different ways of looking at it in terms of the statistics, which I think I'm just going to jump over for the moment. I'll put that on there, so it's on the YouTube video. So now then the next question people always want to say is, oh, well, does it work for older people? Does it work for children? Does it work equally for men and for women? Does it work if my parents had Marfan syndrome? Did it work if I've got a big aorta to start with or a small aorta? Does it work for people who've got high and low blood pressure? Does it work if I also take a beta blocker? These are all very good questions. And the short answer is that we found, I'm going to get this right, otherwise my statistical colleagues will sort of raise an eyebrow at me. And the correct way of saying this, I think, is to say that we explored the data for evidence of differences because of these things. And we found no evidence that it made any difference at all for any of these things. Okay. If I'm being properly statistically correct about it, that is the way I should say it. Okay. We found no evidence for any differences according to any of these subgroups. We looked for whether people were, for children, young people under the age of 16 compared to over 16. We found no evidence for any difference. We looked for whether it was different for men and for women. We found no difference. We looked for family history. We looked for people with big aortas compared to small aortas. We found no difference. Okay. I think what people would like me to say is to say that it makes no difference. That is going very slightly beyond what one can say from these types of data sets. But I think I recommend these medications to men and women. I recommend it for children and for adults. I recommend it for people with high blood pressure, low blood pressure, big aortas, small aortas. And if I fell into any of these categories, I would be taking I'd be considering these medications for myself, for my children, for my sister, for me, my mum, my dad, whether someone had a big aorta, small aorta. That's how I would be approaching this. And I see no rational reason for denying these medications for certain people. Some colleagues say, I like to individualize things. I like to tailor things to the individual patient. And with very limited number of exceptions, what I like to ask those colleagues is, on what rational basis do you do that? Because I can find no rational basis for doing it, apart from one or two very limited exceptions. Okay. I think there are a couple of things that I think are important, that is, I need to emphasize. That when we looked specifically at beta blockers, we found that patients with beta blockers had exactly the same, we found no evidence for difference in patients who are on beta blockers. Now, that strongly implies to us that the effects of these medications are similar in patients who take beta blockers to those who don't take beta blockers, implying that the effects of angiotensin receptor blockers are similar to those who are taking beta blockers to are not taking beta blockers. So that implies that the effects are likely to be additive. So in other words, the effects are likely to be independent of beta blockers. And the other thing is that the one thing that we did find that was different is that the effects of angiotensin receptor blockers were different in patients who had FBN1 mutations. So there were some patients included in the trials who did not have FBN1 mutations. And when we looked at those patients, we found that we did find evidence for heterogeneity for the FBN1 mutations. So patients who had FBN1 mutations at baseline were more likely to have an effect of angiotensin receptor blockers. Angiotensin receptor blockers were particularly likely to be effective in those patients. Now, that's not saying that if you don't have an FBN1 mutation, the ARBs won't work. They may well work, but the ARBs had a particularly strong effect in FBN1 mutations. And what that means is that strongly reinforces our belief that the angiotensin receptor blockers are effective in Marfan syndrome, because you would really expect the drug to be most effective in people with FBN1 mutations. Okay, and then we then went on to look at trials where they had compared angiotensin receptor blockers with beta blockers. This is a different kind of trial, ARB versus beta blockers head-to-head comparison. And this was the Pediatric Heart Network trial that was supported by the Marfan Foundation in the States, the Spanish trial, and the Canadian trial. They were comparing head-to-head trials. And what that showed is that the diamond kind of overlapped in the middle, okay? And that meant that ARBs and beta blockers have comparable effect sizes. So that means that if you are forced into a situation in which you can either take an ARB or a beta blocker, and it's one or the other, then probably the effects are pretty similar, okay? And so ARBs and beta blockers are probably fairly similar to each other in terms of their effect size. But as I showed you before, if you're on a beta blocker, you'll probably get additive effects from an angiotensin receptor blocker as well. So I think it makes sense to be on both. We were able to, I'm just going to skip that slide for 1 second and come back to it. We were able to do a clever little statistical analysis that my colleagues with statistical brains were able to come up with, which allowed us to estimate the effects of beta blockers. And we found that the effects of beta blockers were effectively comparable to the effects of angiotensin receptor blockers. So we think that beta blockers work as well, and we've been able to add the pile of evidence that suggests that beta blockers are effective, which also comes from other types of evidence as well. I'm just going to go back and say that we were able to explore, one of the questions was, was there evidence that these medications reduced the rate of tearing of the aorta and things like surgery and that kind of thing? And the answer to that question, and this may be difficult for people to understand, but I'll explain it the best way I can. the answer is that this may be surprising. There were not enough patients, thankfully, having aortic tears or aortic surgery or dying in these trials. And this is a positive message, I think, for everyone on this call. There were not enough patients having aortic tears or having surgeries or dying, thankfully, in these trials for us to draw any meaningful conclusions about whether these medications impact on these things or not. Okay, and that's because these patients were diagnosed, they were being followed carefully by experts who knew what they were doing in good centers in America and in Canada and in the UK and in other European countries. They were compliant with their medications. They were on good medications like beta blockers and ARBs. They were having regular echoes. They were having surgery when surgery was necessary. And they were only being followed over a short number of years, 2, 3, 4, 5 years. And that's a very positive message, because look here, you know, this is data from 1,500 patients approximately who were followed over 3, 4, 5 years. And in the patients given ARBs, there were 0 deaths. There were 0 aortic dissections. What a fantastic message for you guys, you know. So you know, that's in the ARB versus control trials. So I think this sends a very optimistic message. Some people have tried to use this information to suggest that the drugs don't reduce these clinical outcomes, but that is a misunderstanding or a misinterpretation of how to interpret meta-analyses, I'm afraid to say, and I do not agree with it. The goal of the meta-analysis from the outset, the primary outcome of the meta-analysis was to look at whether it reduced the rate of enlargement of the aortic root, which is a very, very important measure in Marfan syndrome. If I had Marfan syndrome, I would not want my aortic root expanding rapidly, because that's how we decide whether to do aortic surgeries, and it's the best measurement we've got for deciding whether you are in trouble if you've got Marfan syndrome, and it's how we decide whether you have surgery or not. And you know, what I try to do with patients with Marfan syndrome is I try not to let them get into a situation where their aorta gets to these dangerous levels. And it looks to me like my colleagues who are running these trials in these countries were doing a fantastic job of that by and large, and so they should. And that is not. And so there were not enough events in order to make reliable conclusions about whether the drugs impact on these clinical events. I hope I've explained that as well as I can. Okay, so I'm now going to just skip forward and just draw some conclusions from the trials. So angiotensin receptor blockers reduce the rate of aortic growth in Marfan syndrome. The effects of ARBs are largest in those who've got mutations. Beta blockers are effective in indirect analyses. There's no evidence of any interaction with the medications. And the decision to operate is determined by aortic root size and growth rate. So medical treatment should be expected to delay surgery and aortic tears substantially if these are given for a number of years. And so I would recommend giving these from a young age if possible. I'm going to just talk about a couple of other issues now. There is, in particular, I want to talk about the medications that we should not be giving. And I'm sorry I'm running a bit later than I said I would. It just took me a bit longer to explain those things, and then we'll go on to some questions. So if Eileen thinks there's time. So fluoroquinolone antibiotics. So there is some evidence to suggest that a group of antibiotics called the fluoroquinolones, and the drug that's most widely used, certainly in the UK, is a drug called ciprofloxacin, often called Cipro. It is well established that this medication can cause rupture of certain tendons in the body, the connective tissue, especially the Achilles tendon. And I've definitely seen patients myself where they have had a tear of the Achilles tendon in the heel of the foot. I've definitely seen that myself. That's well established, no doubt about that. Now, that has led people to think, well, that's interesting. Maybe that could cause a wider problem in connective tissue. Where else do we find connective tissue? In the aorta. And there is some data that suggests that some people have had increased risk of aortic dissection, and current use of fluoroquinolones has been associated with a 2.9 times increased risk. So, nearly triple the risk of an increased risk of aortic tearing. And people with Marfan syndrome have a much, much higher risk of tearing of the aorta. The risk, is people with Marfan syndrome have a risk that is like 100 times higher, 150 times higher than the normal population. And young people with Marfan syndrome have an age-adjusted risk of maybe 500 times increased risk compared to the normal age-adjusted population. And so if you triple that, it starts to get very, much higher relative risks. And so maybe that would be a type of medication that you should be looking to avoid. So I think that there is some conflicting evidence has recently been published as well that says maybe that risk doesn't exist. And so I think the evidence is conflicting. I think the way I approach this is to say, if this medication can safely be avoided, then I would avoid it. If there's an alternative medication, I would choose the alternative. If there's no alternative and the infection is really serious and this medication has to be used, well, I think you and your physician have to weigh up the risks and benefits. And I could imagine that there are certain patients where its use could be justified, but let's not use it willy-nilly. Is that a British phrase? I think it probably is. Okay, and here's some mice data that shows that here's some mice that have been given ciprofloxacin, and certainly mice that are prone to getting aortic dissections when challenged with ciprofloxacin and other agents to increase their risk of aortic dissection. Bad things can happen to their aortas. Okay, so that's that. So that's a bit more data about it. The next thing I want to bring to your attention is that there are medications called calcium channel blockers. These are medications like verapamil, diltiazem, nifedipine, things like that. They're widely used to lower blood pressure, and historically they have been suggested as treatments for Marfan syndrome. But again, this is data from Loeys-Dietz and his lab have shown that use of these agents is associated with dramatic expansion of the aneurysms in mice and tearing of the aorta, and it is really bad for mice with Marfan syndrome. There is some fairly limited data from the GENTAC registry, again done by Loeys-Dietz and his colleagues, and these are medications that I try extremely hard to avoid in anyone at risk of aneurysm conditions. And I think that there are almost always medications that can be used instead of these drugs, and I now avoid them myself. I don't think everyone else in the field does that myself, but I'm not alone in doing that. So I don't think these medications should be used, or I don't use them, and I would try to avoid it. This is a bit more controversial, perhaps. There are a group of medications called triptans. These are used for migraine, and usually used as an acute treatment. They're not used for prevention of migraine. They're used to terminate an episode of migraine. They cause blood vessels to constrict and can cause rises in blood pressure. And the data for this, I think, is very sparse, but I have definitely heard of and have met small numbers of patients who have had migraines, or what they think is a migraine. They've taken a tablet, a triptan medication, and then within an hour or two of that having happened, they have had aortic dissections. Now, these are very small isolated reports. This is not strong evidence, but I've heard enough to make me anxious about it, and I think other colleagues have had similar experiences. It's a little bit difficult to be certain about it. Maybe were those symptoms they were experiencing perhaps not migraines, and actually the first symptoms of aortic tearing, something like that. So I'm not sure about it, but I would prefer for patients like that to be on medications to prevent their migraines from happening in the first place, rather than maybe taking medications to terminate an attack. Perhaps that would be a better strategy. So I try to avoid triptans wherever I can. So let's go back to the take-home messages. What I would like to convey is that there is now a very substantial evidence base for good medical treatment for patients with Marfan syndrome. Angiotensin receptor blockers from a young age, I think in childhood, probably at high doses, and especially for fibrillin 1 mutation patients, are a good idea. I think any angiotensin receptor blocker is probably effective. I think that irbesartan is probably the strongest and most effective. I like to start with small doses and then build up slowly to high doses. I think it's a good idea to try and get onto the maximum dose that the patient can tolerate. And that is 300 milligrams in the UK. I don't quite know what it is in the US. I think it's the same. I think if you don't get on with one ARB, I try another. I think losartan is also fine. The dose in children in the UK is 2 milligrams per kilogram, up to a maximum of 100 milligrams. In the UK, there is an argument for going into 150 milligrams if you can. You have to discuss that with your care provider. I think that these medications can be used in combination with beta blockers. I think it makes sense to try and get the beta blockers to the maximum tolerated dose. You can either use atenolol or propanolol. I think other beta blockers are probably fine as well. Again, you want to start at a low dose and build up to a high dose. And it's probably best to use calcium channel to avoid calcium channel blockers, fluoroquinolones and triptans. Lifestyle measures are very important. Surgery is available if the aorta becomes too large or expands rapidly. And also I want to give you a very positive message, which is to say that in the trials, there were very few events that were bad for patients. And there are, I know for sure, many new therapeutic strategies in development. And the landscape for treatment for patients with Marfan syndrome is completely transformed compared to the situation even 10 years ago, and certainly compared to 20 or 30 years ago. Eileen, I'm really sorry I've run over my time.
No.
Do you think there's time to, I hope I've covered many of the questions, but do you think there's time to cover more things?
Yeah, if you have a little bit of time, I mean, I'm happy to stay on, and I welcome anybody else to stay on. I mean, I'm looking at these questions and I do see some very specific things, and you've addressed a lot of this. I did see a question somewhere, I don't see where, about potential treatments for babies with neonatal Marfan syndrome. Have you looked at any of that at all with neonatal cases?
So the term neonatal is often a bit misused. Neonatal Marfan syndrome is a quite rare and very specific form of Marfan syndrome in which the child is really quite severely affected at birth. I think the term is sometimes probably incorrectly applied to patients with Marfan syndrome where the condition is identified at birth, but where the child is not severely affected. And I would think that in both cases, it would make a lot of sense for the child to be treated with angiotensin receptor blockers. The youngest children enrolled in the ARB trials were 6 months of age. That was in the Pediatric Heart Network trial in the States. But I do know that children as young as 8 weeks of age have been treated with ARBs successfully, and that it has in fact even been given to children just a few weeks of age.
Right. Yeah, we get a lot of questions about supplements that are not medication, and there's one question here about copper supplementation that can reduce the size of aneurysms. Have you heard anything about that? Have you ever looked at that? Do you have any data about any supplements?
Yeah. I'm not aware of any supplements having been subjected to reliable studies, and I think I would know if they have. So I think I could say confidently that there is no strong or reliable evidence for any of those being effective. There's a question someone saw there was the interpretation of the fluoroquinolone data being that even prior use of fluoroquinolones having been associated with aortic aneurysm, and it is the case that is the correct interpretation of the slide I showed. Yes.
Right. And when you talked about losartan and giving the maximum dosage, given the based on the side effect profile that you could tolerate, somebody did write about the daughter who lowered the dose, but she's still having dizziness and headaches after that. So can you talk a little bit about tolerating risks and the benefits of losartan?
Yeah.
How it works with patients?
Yeah, I mean, the truth of it is we don't really know the right dose for people. So what I say is start low and go slow. Take your time. You could do it over 6 months or a year. The aorta expands incredibly slowly in Marfan syndrome. So what matters is can you get there, not how quickly. So take your time. Hydration is very important. And just get to the maximum dose you can, and it's better to be on some than nothing. It's great if you can get to a high dose, but if you can't, don't worry too much about it. I think some level of dizziness, I think to some extent it's the price of having an aorta that stays stable. And I think I get dizzy sometimes. If I get up quickly, too quickly out of bed or whatever, or sometimes when I'm looking at the bottom bookshelf in the bookstore, if I stand up quickly, I get a bit dizzy. That's a universal feature of life. If it's happening 3 times a day, that's too much. But if it's once every 3 weeks, live with it. So and then I would just you've got to make a judgment for yourself. So but there are lots of tricks and workarounds. There's a thing called dynamic maneuvers, which is where you kind of squeeze you sort of put your arms together, and if you put your, maybe I'll just demonstrate this.
You want to stop sharing and we can see you?
Yeah.
There should be a button to stop share.
Where's the stop share thing?
Let me see if I can do that for you.
Yeah, stop share. I found it. Yeah.
You got it. Okay.
Yeah. So you sort of take your fingers together and you sort of pull like this, and you kind of strain at the same time, and that just pulls a little bit of blood from your arms into your venous system, and that just gives you an extra 200 mils in your central circulation. That can help. And also if you kind of cross your legs over and squeeze your legs together, that can help. And guardsmen, the guys with beard, with hair, the big hats outside Buckingham Palace, they're taught to unlock their knees and wriggle their toes, and that's how they stop fainting. There's videos on YouTube of them doing that and things like that. So you can do that to help a little bit with dizziness. And the other trick is to have a pint glass in the UK of water, not beer, next to your bed at night, and then you drink that before you get out of bed, and that can help with hydration.
Yeah, I would say water, not beer. There's a question here from somebody who has had an aortic surgery. And so whether it's pear surgery over there or another kind of aortic surgery here, what's your recommendation on losartan or beta blocker afterwards?
Yeah, the meta-analysis did not look at people who had had prior aortic surgery. And so from a meta-analysis perspective, I would say that there is no meta-analysis data relevant to that question, I'm afraid. There is data from one of the trials. The Dutch trial did look, I believe, at the rest of the aorta afterwards, and did seem to suggest that there was some data that losartan was effective at protecting the distal aorta afterwards, because there is still a risk for the rest of the aorta beyond that bit. So I would try and stay on it, I think, and I would also try and be on a beta blocker. But the data is not as strong. Yeah.
Okay. I'm just looking at these questions here to see any here's a good question about long-term effects of the drugs that you talked about. How far out did you look? I know some of these drugs are on the market anyway here, and they have very safe profiles, but did you look at long-term?
Well, the meta-analysis was only available to look at data trials that was in the data that already existed. The trials went out to 5 years. The safety profile was, I mean, there were hardly any clinical events. It was exceptionally rare for people to have the common complications that are known from ARBs. But the best way to look at safety for ARBs in general is just to look at the long-term follow-up of the, I mean, there must be millions of people who've taken ARBs over the years of all ages and for various other conditions. And these are some of the safest drugs there are. I think there are a few precautions. It's sensible to have kidney function tests and electrolytes tested before you go on them, and then 1 to 2 weeks after you started, and then annually thereafter, something like that. So there are some precautions, but these are almost I mean, Loeys-Dietz describes these as almost like wonder drugs in terms of their safety profile. They're some of the safest medications there are, I would say. And when you compare them to the I mean, untreated Marfan syndrome is a dangerous condition. There's no getting around that, and it's a really, untreated and unmonitored, it's dangerous. With monitoring and treatment, it's still serious, but it's it can be transformed with careful care.
I know you focus on the medical management, but you did talk about lifestyle a little bit. And there's a question here. Can you talk a little bit about lifestyle and physical activity when you're taking these medications? I know I've heard you talk about this before, so maybe you could add something here for everybody.
Yeah. So I don't think the medications change the lifestyle restriction, the lifestyle modifications really, and lifestyle advice. I think lifestyle advice, I mean, in a way, it's a talk of its own. I think the headlines are that I think it's important to stay healthy in all kinds of ways. Really, much of the lifestyle advice it's the same advice for much of it is the same advice for everyone else, but it's really important. I think exercise is a little different. I think that it's important for everyone to get exercise. You don't want to be gaining lots of weight, which tend to happen with Marfan syndrome later in life for many people. It's important to exercise regularly, but certain kinds of exercise are good, and certain kinds of exercise that other people might be recommended are not a good idea. And in particular, you don't want to be doing weightlifting, certainly not heavy weightlifting. You don't want to be doing exercise to exhaustion, like high intensity exercise. You don't want to be doing sort of really heavy sort of contact sports where you might kind of get kind of winded or something like that. And really kind of competitive exercise where the whole idea is to kind of beat the other person, like kind of squash maybe or something like that is not ideal. And so really kind of competitive exercises are not great. And so but there are still lots of other exercises like jogging, swimming, those kinds of things that are still really good. And I think it's often a good idea to try and work maybe with a personal trainer who understands the condition, or a physiotherapist maybe who can help, or an exercise scientist who can help with it, and to think about maybe zone 2 type exercise, I think it's called now. That could really help. But really, I think that's something that one's own care provider should be talking to you about and going through with you. And maybe there's resources from the Marfan Foundation or the Marfan Trust that could help with that. We spend quite a lot of time working with patients about that, because it's quite a difficult balance to get right. And in the past, I think we've probably been a bit overcautious in terms of what we've advised, and have had people get the impression that, oh well, I can't exercise because I've got Marfan syndrome, and then that's led to quite a lot of problems downstream with obesity and diabetes and that kind of issue.
Yeah, exactly. Well, there are still a lot of questions, but I think we're gonna think we could keep you all night. We're not going to do that. So just going to share my screen and just give everybody this this website again. I hope you can see that now. You see Jen there as our help center. I know Marfan Trust also. Victoria there answers questions too. But that's Jen, who's the nurse in our help center. And if you submit through our website, she can answer the questions. I will take the questions that you guys typed in here and share those with her, so that we can get these questions answered for you. And if she can't get the answers, I'm sure she'll contact Dr. Pitcher or one of our other doctors to get those answers for you. So I want to thank you all for being here. There's a couple more things to let you know, things that are coming up. We mentioned earlier our International Patient Symposium, which is going to be a one-day event in London on August 31st. More to come on that. The Marfan Foundation in the US having a virtual conference in June, and hopefully some of those times should work for you guys, no matter where you are, in the UK or here in the US. We have a global walk on June 22nd, which is daytime here, which should be accessible for everybody. We can certainly have Team Ireland, Team Great Britain. That's always a fun event for people around the world. And we have virtual support groups. And so that's just what we offer. And if you don't get our emails directly, you can just go to marfan.org and just scroll to the bottom of the page and sign up for our emails if you don't already get them. What else do I have here? And for those people who are here in the US, I know there's a lot of people from the US who registered for this today. We do have a lot of walks to come, so you can meet people in person. But we know in person's great, and that's why we're doing this international meeting in person in London, so we can meet everybody there as well. And I know you all get together there, we get together here, so it'll be nice to all combine and get together with not only each other, but some of the doctors who are experts in the field. So I just want to thank everybody for being here. Alex, do you have any final words about today's presentation, or just moving forward, how we can work together?
Yeah, well, I've had a fantastic time this evening, and I just wanted to thank everyone for coming along, and send more questions to the Marfan Foundation. I'm more than happy to try to answer them if I can. Excellent,
great. And thank you to Victoria, who I don't see here, but has been my partner in this, and I know we'll be working together a lot in the days, months, and years to come. So thank you, everybody. Have a great night.
Thank you. Bye.
Thanks a lot. Bye.